One, we're going live. Good evening, folks. We're going to wait a few minutes until all our participants populate a little bit, and then we're going to get started. Okay, I think most of our folks are on or they'll be on shortly. I want to welcome everybody to the New York Chiropractic Council All District Meeting webinar on telehealth record keeping, compliance, and documentation, take 2. I'd like to thank Dr. Marty Kotler and Dr. John LaMonica for agreeing to do this for us again, for those of you who couldn't make it on with us last week. I'd also like to take this opportunity to thank an anonymous council member for donating sponsorship to this webinar. It's very much appreciated. I have nothing else to share with you, so I'm going to turn the floor over to Dr. John LaMonica.
Thank you, Barbara. Good evening, everyone. Thank you for joining us today. And before we get started, just a few things. Number one, of course, I always would like to thank Dr. Marty Kotler, my good friend. He is always ready and willing to be there for us and the entire profession with his knowledge, skills, and expertise in coding, compliance, Medicare, HIPAA, etc. So once again, he's always there for us. And Marty, really, we do appreciate everything you do. Thank you so much. I'd like to thank the entire council board, especially the executive board, which has been working tirelessly all the time, but even in these challenging times, even more. They're up for hours and hours and hours at a time. So if you ever get a chance, maybe give a phone call and just give a thank you, a shout out to them. Your president, Dr. Joe Badilli, your vice president, Dr. Greg Rubenstein, your executive officers, Dr. Donna DeRosa, Dr. Brian Ludwig, and Dr. Anish Bajaj. You know, they've just been unbelievable to work with. These are the times when you realize, when you have an organization behind you and good people working for you, why you have that organization behind you, standing strong, fighting for us. And you know, that's why we're putting out all this information to you. Also, with all the hard work, we're able to get direct contact with not only the Department of Financial Services with no fault, but also the Workers' Compensation Board and also the State Board of Chiropractic, which we were able to get approval for this in this crisis time because of this topic. Barbara was able to get a credit for us very, very quickly, actually within a day, because of the work we've been doing with them and the relationships we had. I also want to thank the members and all doctors of chiropractic, because if it's not for you guys and girls, we wouldn't be doing what we do, and you know what, we wouldn't have the great profession we have. It's like the anonymous donor who's a member sponsored this because they know the hard work we need to do. We need some money to do that. But also the people that joined the webinar, there was a great portion that chose to do the voluntary contribution, and we thank you for that as well. So that's one thing. Second of all is, as I said, because of our relationships, we are able to have direct response. So a lot of the information I am going to be giving you from the New York side of it is directly from written confirmation that we have from the board. And when we give the information, it's not giving any proprietary information, because we got public responses for that. One thing I do want to share, very, very exciting news. We've been working for years with the legislature, as you know it, and many people do know this. We just got a notice today, and it's been out on our website. If you haven't seen it, it's on our Facebook. It's on our email list. We just found out that in the 11th hour, they added a pilot program for chiropractic to the New York State budget, which it's a pilot program for non-pharmacological treatment of the opioid treatment of low back pain. Now, I know it's a low back pain study, but this is what they were focusing on. We've been fighting for this in the bill. Weren't too happy with the final language of what the bill was, but we had to accept it because they were putting it through anyway. But we just found out they put into the budget a pilot program that specifically mentions acupuncture and chiropractic. And I'll just read to you quickly what it actually says. The Commission of Health is authorized to establish pilot programs in one or more counties or regions of the state for the purpose of promoting the use of alternatives to opioid treatment for individuals suffering from chronic lower back pain by offering access to non-pharmacological treatments such as acupuncture and chiropractic services. So in that budget bill where mentioned by name, that would not have happened without the efforts of many people in the council, especially people that testified at the hearings, Dr. Joe Badilli, Dr. Brian Lovewood, myself, and people that have gone to the events. The legislative committee I want to thank as well. So that's a pretty big win. We're going to keep you up to date on the details when they come forth and how the program is going to be initiated. It does have to get approved by the federal government, and we think it will, and then we'll give you more update on that. The next thing is telehealth is what we're talking about. That is the proper term to use whenever we as chiropractors, if we're going to do this in our offices or put it out to our patients, please use the word telehealth and not telemedicine. We want to focus on staying within our scope of practice, as the board has told us. And even many of the other companies and the VA is using the term telehealth because telemedicine is specific to the medicine portion of it, and telehealth is the consulting and management and a lot of the other parts of it. So with that note, like I said, we will give you everything we know up to date at this point. I'd like to turn it over to Dr. Kotler to start the full presentation, and we will add in everything that we could possibly do that we know up to date. Thank you very much.
Okay. Thank you, Dr. LaMonica. Thank you, Barbara. I want to thank everyone over at the council for inviting me to do these webinars. I'm happy to do them. I hope everybody enjoys them. I'm happy to be a supporter of the council. I'm happy to be a member of the council. So let's get going here. Just a disclaimer, we don't provide legal services. I'm not a lawyer. Also, I'm not going to be, providing information that should substitute your thorough clinical decision making. I've made every attempt to make certain the information in this presentation is 100% accurate. However, it's not guaranteed and it's changing all the time. So yeah, got to stay up to the, up to date on the latest stuff that's going on. So again, my name is Dr. Marty Kotler. I practiced in White Plains, New York for many years. I'm also a certified professional compliance officer, certified billing and coding specialist. We help chiropractors and their staff members all over New York, New Jersey, Connecticut, and many other states on compliance as it relates to billing, coding, documentation, Medicare, HIPAA. So let's get going. Telehealth, coding, compliance, documentation. This is new to a lot of people. And it is something that could be challenging. Chiropractic is a very hands-on profession. So how can we, we can't adjust patients through your phone, through a phone or computer. So how could we utilize telehealth services? So that's what we're going to be going over today. And just to be clear, this webinar is not necessarily about making money. You don't have to do telehealth at all if you don't want to. I can tell you probably about 20% of the doctors that I, work with and been serving have no interest in doing it. 80% are interested. And the longer it goes on, the more interest I think people will have. So you don't have to do it at all. You don't have to charge for it if you don't want to, or you can charge cash if you would like. So you could perform the services, document everything you do, and then maybe when the dust settles, you could submit the claims and see how things are going. I already have some docs I'm working with. They've already submitted claims, and some of them have gotten paid already. So, that's what we're going to do. We're just going to try and help out as much as possible, give you as much information as possible. So here's some of the, key points. Telehealth refers to the exchange of information between a patient and a provider. These are non-face-to-face patient-initiated communications. A lot of the stuff that's going on right now is falling under the Social Security Act, Section 1135. You may hear the term, the 1135 waiver. a lot. Actually, I'm going to be touching on a few things that are part of that waiver. And there's many types of telehealth visits. Just your regular telehealth visits, that's what I call them, your standard visits. And then there are e-visits, virtual check-in visits, telephone consultations. That's a really important category, which we're going to cover in detail a little bit later as it relates to workers' comp and no fault. And there's interprofessional telephone consultation. So a lot of different things that could be done under telehealth. Here's a website. It's a very good resource. It could give you some information about state-specific stuff on telehealth, cchpca.org. As far as I know, telehealth is within the scope of practice in New York. Correct me if I'm wrong, but chiropractors in the state of New York are allowed to do telehealth. I just found out Kentucky is not allowing chiropractors to do telehealth. I was really upset when I heard that. So New York, it is okay. So here we go, regular telehealth visits. These are going to be interactions you're going to have with patients through a live video conferencing. It's a real-time communication. It's called synchronous between the patient and the provider. If you're going to do these, you should tell the patients in advance that, there are some HIPAA risks by doing this. That's why, we strongly recommend getting a telehealth informed consent form from your malpractice insurance company. So the patient should have a relationship with you. Now, can you do this for new patients? This is something that maybe Dr. LaMonica wants to chime in. As time goes on, I'm getting more and more information solidifying the fact that you can do telehealth with new patients. But, I'll defer to John a little bit more on that later. But most of these patients that you're going to be doing this with are your established patients, because you're going to let them know that you're offering it. We're going to go over that a little bit later. So if it's a new patient, again, it's supposed to be an established patient, but if it's a new patient, according to the federal government, they're not going to conduct audits on that type of relationship. So with telehealth visits, you could use FaceTime, you could use Zoom. These, if you have an iPhone, you have FaceTime automatically, as one of your apps. There's Zoom, there's Skype. So these are very common apps and platforms that you could have face-to-face. Well, they're not face-to-face, but these live video conference calls. Now, under normal times, pre-coronavirus outbreak, public health emergency, if a doctor asked me, hey, Dr. Kotler, I want to do a video conference with a patient. Could I use, FaceTime, Zoom, Skype? I would have said, absolutely not. You have to use a HIPAA secure platform. You cannot use FaceTime. Well, under the 1135 waiver, that rule has been relaxed. Now, I strongly recommend you get a HIPAA secure platform, but in the interim, if you want to do this temporarily, you could use FaceTime, Zoom, Skype. But again, under normal circumstances, if you were going to use, and maybe down the road, even after the dust settles, I've been hearing from a few of the docs that we work with that they want to do telehealth after this whole COVID-19 emergency is over. So once you switch, you'll be much better off. Switch to a HIPAA secure platform as soon as possible. So back to what I was saying, if you're going to use any type of live conferencing platform, you have to go through a full risk assessment. I mean, this is HIPAA stuff. This is mandatory in every state, including New York. A HIPAA security risk assessment would have to be done. It's not a big deal. You just got to get these companies to sign a BAA and do a couple of other things whereby they would sign a form and you'd ask them a few questions. So not recommended is Facebook Live and TikTok. These are too public. If you can't do a patient consultation in private on Facebook Live. The whole world could see that if they wanted to. So the codes, here we go. Billing. How do we bill for these services? The codes you're going to be using are your standard E&M codes like 99212, 99213. And you're going to use counseling and coordinating of care as your basis with the time override. because that's also been, a frequently asked question we're getting here at Target Coding. Like, Dr. Cutler, how could we bill an exam? How could I do an exam? How could I, you always talk about those bullet points, range of motion, palpation, tenderness. How could we do that over the phone if we're going to bill an E&M code? Well, you can do a little bit of an exam. However, if this is going to be a counseling and coordination of care session, you could use time as the override. And the example that I was talking to Dr. LaMonica about the other day was, just go back into your office, right? Picture yourself in your office. You walk into the room. Hi, Mrs. Jones, how you doing? And now she starts to go over things with you or ask you things that have nothing really to do with that visit. For example, the patient says, hey, Dr. Kotler, I've been coming in here about 3 weeks. I just don't feel like I'm getting better as fast as I thought. I don't understand what's going on. Maybe should I see a surgeon? Should I have surgery? Should I go see my orthopedist? So now you're having a conversation with a patient, and this could be considered counseling and coordinating care, where time becomes the overriding factor. So it's information like diagnostic results, prognosis, risks and benefit of management options, instructions for management options. Here's another example. Let's say you're doing a telehealth live video conferencing call with a patient, and the patient looks like they are in severe spasm. Like, it doesn't look like they could hardly even get out of a chair. You have to make, right? Aren't there some decisions that you would have to make, some clinical decisions about, what type of treatment should this patient get? Should they call 911? So that's counseling and coordinating. Another scenario that might come up is a patient brings in a whole bunch of lab work. Again, this is back in your office, lab work, or, they bring in a whole bunch of MRIs and you have to spend time. So I went over this with Dr. LaMonica. Dr. LaMonica, you want to chime in, remind me some of the other things we spoke about?
Yes, I would. Thank you. First of all, I'd like to just say, if you have a question, please use I don't think Barbara said this today, but please use the question and answer box. It's a little bit more difficult to focus on the chat box. We will be going over as many of the questions as we can at the end. That's number one. Number two, I just wanted to say that, first of all, Dr. Kotler is speaking about the majority of the commercial insurances, even when it comes to Medicare. When it comes to Medicaid, these codes will not be used, as I speak about in a little bit. But what Dr. Kotler was trying to explain to you is that even, this is the conversation we had, 99201, 99203, 99213, either examination codes or re-examination codes, which is what we can be using. Even in the office, what Dr. Kotler was saying is that if the coordination and care portion of it overrides, and the time overrides the 10 to 15 minutes, the 15 minutes, I'm sorry, is now the other portions or components of that 99203 or 99213 are overridden by the time and does not necessarily have to be done in its entirety, so you can still bill that code. Marty, am I correct on that?
Yes, I just wanted to clarify. I didn't want to confuse anybody. You mentioned something about Medicare paying for these codes. Medicare will not pay chiropractors for these codes. But if you're billing regular commercial health insurance, for example, 99212, then they should pay you for 99212 as if you did it in your office.
Right. I guess what I was saying is that Medicare has allowed telehealth, but because they only cover the adjustment codes, they won't. So thank you for clarifying that.
Yeah. And, I know we're all chiropractors on here. That's 98% of my business, but about 2% are nurse practitioners and physical therapists. So nurse practitioners will get paid by Medicare for these E&M codes. So just wanted to, clarify that. Okay. Next, we're going to move on to, I kind of mentioned this already with the federal government, OCR, Office for Civil Rights, which oversees HHS and HIPAA. They're saying they're going to relax the rules on FaceTime and Zoom and Skype. So there's a link. I've checked out a few of these, like Zoom for Healthcare is really cool. Doxy.me, that was, that was a very simple one to get started on, and it's free. And here's the information about from the federal government. Again, they're relaxing the rules. If you bill a regular health insurance company like United Healthcare or Blue Cross Blue Shield for a 99212, as I mentioned, or 213, federal government is saying that they are not forcing providers to collect the co-pays and co-insurance. You can, and if you want to, you should, but you don't have to. And this policy is being adopted by most regular health insurance companies. Again, it's under this 1135 waiver. And there's also some out-of-state situations here under the 1135 waiver where if you're licensed in New York and you want to provide telehealth in New Jersey, is that okay? I don't know yet. I don't know if anybody has, Dr. LaMonica or anyone has any updated information on that, but if we don't, I say stay in your lane, stay in New York. Now, here's a question that has come up. So, Dr. Kotler, I'm in New York, I practice in New York, my patient lives in New York, but due to the coronavirus outbreak, my patient has left and has gone to Illinois to be with family. And now my patient is in Illinois and wants to have a telehealth conference call with me. Is that okay? I say no, the patient is not in your state. So I would not do that. Dr. LaMonica, any comments on?
Yeah, I was in this crisis time, and I thought you had checked on this as well, that they were loosening up the restrictions and things like that. And if it was an established patient and somebody had a question, you probably would be okay with it. They probably wouldn't come down on you that hard. We will double check that to make absolutely sure. But there was two other questions that were with this criteria lightning, so I think we could just answer them. One was being that they're loosening up all these platforms, Dr. Kotler, the Zoom and the FaceTime, what is a HIPAA compliant if it gets down to that point? That's number one. Number two.
Wait, let me just answer it. It's right on here. Skype for Business, UpDocs, VC, Zoom for Healthcare, Doxy.me. These are all HIPAA compliant platforms.
There you go. And then the other thing was about an IME with this. They've loosened up that. I think they're actually foregoing a lot of these IMEs for now because of the social distancing. So at this point, I'm not even going to, we don't have any information that they're going to be doing the IMEs because of the criteria, loosening.
Okay. So you are allowed to tell your patients that you offer telehealth. It's okay. You're not taking out a full page ad in the New York Post advertising that you're doing this. You're telling your existing patients that you offer telehealth. That's fine. You can do it. Next are e-visits. So these are visits that also has to be with an established patient. And this is something that you would be communicating with patients through an online patient portal. Most of the chiropractors that I know and work with do not have online patient portals through their software. So what am I talking about? We're talking about a portal where you would send the patient an email. First of all, you'd have to have certified software to do this. So you would send the patient an email, and then they would click on the email, and then they would create a username and password. And now they have access to their records. They can go in and see what exams were done, your diagnosis codes. If a patient has a question, they could email the doctor a question through this portal. The patient has 24-hour access. So if that's something that you have and you're interested in doing, here are the codes: 99421, 99422, 99423, and it's based on time. These are brand new codes as of January 1st. These codes were not created in response to the coronavirus outbreak. These were around before the whole outbreak occurred, so they're relatively new. Ready? Here we go. So now we have some e-visits that are assigned to non-physician providers. Like who? Physical therapist is the best example I can give you. So that's 98970, 98971, and 98972. They're also time-based. And then we have another set of e-visits. We have 3 sets of e-visits. This is the third set. These are done also by non-physician practitioners, like speech language pathologists, occupational therapists. This is an assessment. These are specific for Medicare. They're HCPCS code G2061, 2062, 2063. So those are e-visits that Medicare requires. Also, they are time-based. Next, we have virtual check-ins. Okay, so with this, what system is required? To recap, the first telehealth visits, live video conferencing, e-visits, online portal, and now we have the third set, virtual check-ins. These could be done with phone or live video conferencing. There's an option there. If you just want to talk to the patient through the telephone, virtual check-ins do allow that. G2012 is the code. There's only one code, that's it, for this virtual check-in. So that's something that would be within the scope of a chiropractor. If a health plan paid for it, it's for doctors that could do E&M services. So G2012 would never be used by a PT or an occupational therapist, be used by MDs, DCs, nurse practitioners. All right, so yeah, Dr. LaMonica mentioned, telehealth is the all-encompassing term, and that's something that you should mention. I don't want chiropractors to start saying, well, I mean, I would prefer you don't call it telechiro, telechiropractic, telerehab. I know there's teledentistry. I got an email from my dentist that, they're going to be doing some online stuff. So there's teledentistry, but just call it telehealth. It's all encompassing term. And a question that has come in, are e-visits really telehealth? Not necessarily. Under Medicare, e-visits is not considered telehealth, but commercial payers might consider it telehealth. So there's some more information on that. Now the terms synchronous and asynchronous is something you're going to see a lot if you get into telehealth. And there's an organization called the American Telemedicine Association, which I never heard of until about 2 weeks ago. And there's their definition of synchronous. It's interactive video connections that transmit information in both directions during the same time period. And then asynchronous, that's a term describing store and forward, but asynchronous is more like email, text, fax. Synchronous is a telephone or live video. The Office of the National Coordinator for Health Information Technology defines synchronous as live video conferencing, a two-way audio-visual link between a provider and a care provider. I like that definition. Okay, now we're going to get into telephone consultations. The first one here are non-face-to-face telephone services. 99441. Pay attention, everyone. This is a big one. 99441 is a telephone evaluation and management services provided by a physician or other qualified healthcare professional who may report E&M services provided to an established patient, a parent, or a guardian, originating from an E&M service within the previous 7 days, nor leading to an E&M service within the next 24 hours, 5 to 10 minutes. Got that? Good. 99422, 11 to 20 minutes. 99443, 21 to 30 minutes. So now we need to dig a little deeper into that 99441 code because of what's going on with workers' comp and no fault. And I'm going to let Dr. LaMonica come on in and take over.
Thank you again, Marty. Okay, so as Marty was going through all the generalized codes and how to handle it, workers' comp, on the other hand, is very specific. And on March 6th, the Workers' Compensation Board put out a subject number 046-1278, and on 3/16, they issued an emergency regulation, which was in regard to Section 325-1.8 of Title 12 of NYCRR. The reason why I say that is because if you ever do want to look it up, but you want to do it because you want to hear the actual language that they're stating. And this is where not only did we read the language, we did follow up with some email questions and got some clarification in the workers' compensation no-fault system. Remember, it's different than what Dr. Kotler is saying on a lot of the other extremes when you're dealing with the commercial carriers. The recommendation is to actually double check with them. I'm sure Dr. Kotler is going to go into some more details in certain of the carriers, but to be safe, you always want to call them. One of the questions was, and here's what it is. It's for 90 days. As of it stands right now, the Work Comp Board has put in for 90 days as of the March date. So, and are they going to expand it at this point? We don't know until we get to that point. I think you're safe across the board with that time period. And if Marty wants to add a time period to what he knows, please feel free. But the new portion of Section 325-1.8 in the Work Compensation Emergency Reg states, telemedicine using an interactive audio and video telecommunications system that permits real-time communication between an authorized medical provider and a claimant in accordance with guidance from the Centers for Medicare and Medicaid Services may be used by authorized providers where medically appropriate for social distancing purposes due to the outbreak of COVID-19 to assess current disability status. Now, in parentheses, it says right there, medically appropriate includes discussion of test results or imaging, follow-up assessments, or counseling. It does not include treatment where physical examination is a necessary component, such as initial visits or assessments, physical therapy, or other types of manual therapy. The authorized provider shall indicate on their report that such assessment was done using telemedicine as a result of social distancing due to the outbreak of COVID-19. So it doesn't have to be COVID-19, but it has to be related to it due to social distancing. That's number one. Number two, the 90 days. The number three, yes, somebody asked a question about documentation. I'm sure Marty will add to this. You must document everything. Yes, you want to document the time it started and ended. You want to document also that it was in relationship to the social distancing for whatever reason you have that. Now, the last subdivision, a new subdivision of Section 348.2 is Section C. It's on the second page, Marty, if you can move that slide.
Okay, let me just, there we go.
And there it is with the red arrow, and it says authorized chiropractors shall use common procedural technology CP2 code 99441, which is the telephone evaluation and management services provided to an established patient 5 to 10 minutes of medical discussion, where telemedicine is used, like I said above, in accordance with 325-1.8. Notwithstanding this code not appearing in the official New York Workers' Compensation Chiropractic Fee Schedule, and use of this code is limited to 1 unit per patient per day. Now, let me put it in a little common sense English for you. I said it because that's the way it's worded. What they're saying is, we know that code is 99441. They want us to use 99441 and only 99441 right now. So for that case, it's a code that's encompassing everything you're going to be discussing with that patient for that day, for that service. The second thing is that it's saying use of this code is limited to 1 unit per patient per day. And again, this is where some of those regulations we feel were totally relaxed a little bit, because as Marty explained the definition, and that same definition as Marty said, is in the workers' compensation medical fee schedule for that code of E&M, which states that you can't do this 7 days prior if there was an E&M code, or 24 to 48 hours later. They're saying right here that they pretty much waive that, and you can do it 1 per patient per day. But please, please, use your common sense on this. Do not do this every day. 1, it needs to be patient initiated, and don't do what you wouldn't do in your own office. You can't call these patients every day just to check on them and say, hey, what's going on? That's key. So we did get some answers back from both the board and DFS itself, which is the Department of Financial Services, which is the no-fault regulator. And like I said earlier, we are not divulging any proprietary information. It's been out there publicly for a while. We actually got a public email responded to us by the board stating that that is the code and what the correct RVU is. I stated this before, and I'm sure everybody would like to write this down. So for 99441, it is taken out of the medical workers' compensation fee schedule, and the RVU for that code is 5.07. So the way we, of course, make the fee, or come up with our fee for our regions, is by using the E&M conversion factor of your particular region. And of course, those E&Ms conversion factors would be for regions 1 and 2, they would be 6.37. For region 3, it is 7.29. And for region 4, it's 7.92. So that would range from a fee for this service from anywhere from $32.30 up to $40.15, depending on your region. But now just remember, for Department of Financial Services, for no fault, we got a confirmation from them as well, stating that yes, they are following the recommendations of work comp, so we can use this for no fault. But again, they are not implementing, as far as we're aware, any increase in fees. So they are still using the conversion factors from the E&M back before we got that first elevation in workers' comp. They will not go into effect till October. So remember, still using the RVU of 5.07 for no fault. You then would be using the conversion factors in region 1 of 4.44. In region 2 would be 4.65. In region 3 would be 5.32. And in region 4 would be 5.78, which would make your range of fees anywhere from around $22.51 to $29.30. So that's where we are with that. Some other additional information is, questions were asked, do you need a variance for this? And at this point in time, our understanding is that there is no variance needed. This is an E&M code. You usually need a variance for a treatment code. So at this point, you don't. But you still have to follow the way you would do any of the guidelines, making sure you're within somewhat of those guidelines. Again, a lot of it is being relaxed. Somebody had asked the question, can you do it on weekends? We did not see any reason stated that it cannot be done on weekends. I do want to say, as Marty mentioned, do check with your malpractice coverage in case you're not in your office, how to go about stating that you're out of the office to make sure you continue your coverage. Another question was about therapeutic exercises, and this comes down to those exams and how you can do an exam. Remember, this is a code of 10 to 15 minutes. Giving them recommendations of exercises and what to do and checking their ranges should, I feel, be all included in that 10 to 15 minutes. So you wouldn't be able to bill a 97110 with this under no fault of work comp because, as I stated, the only code they're allowing is the 99441 code. But if you use that to explain, give people and patients exercises and how to do certain things, that could be all in your counseling and coordination and recommendations. Let's see if there's any questions right now with the no fault of work comp that I can answer. And I think, Marty, did I leave anything out?
I can't think of anything else right now as far as work comp no fault goes.
Let me just check one other thing. Yes. So right now, that's where we're at with the work comp no fault situation. And I will give it back to Marty now.
Well, I do have actually one question. So yes, this is what about a supply, like a back brace or a TENS machine?
Again, I don't know if that's of course not part of telemedicine in the sense of checking, but when you're doing that, you really need to fit the patient. This is something where I would stay right now. We don't have a definitive answer. I would stay pretty much away from that as it states. There are some lower end races that possibly you could try to um, to try to submit. But with work comp, they have guidelines and rules on DME supplies too. One of the other things I did dig when it comes to an established patient versus a new patient that I would like to just comment on, even though we did get some confirmation that, in the commercials, no fault came back to us, the medical director, and they're a little bit concerned about how can we do that and determine on a new patient what the area of the spine is. So I'm just saying, be very careful on how you document that. If you wanted to document it and say that you just you explain to a patient what to do, maybe preventing them. And this is what I like to get back to them and explain that as chiropractors, we're much more educated than the average person on the street and most professionals out there. We can actually give them some advice to maybe calm their fears a little bit. Tell them to just monitor something for a day or two if we don't feel it's extremely severe, and maybe keep the overflow of the emergency rooms out so they're not just all running to the emergency rooms. Again, be very careful on how you do that. They're not established patients. If you feel of anything of an issue, make sure you refer them to their primary provider. This is something where we could get bitten with after the fact and after it comes on down and after the curve starts on the back end of this. So just be very, very careful with that with the new patients coming in with your call. So like I said, they were very specific in their wording, and we got a very hesitant answer when we gave an email question on that. Does that answer your question, Marty?
Yeah, sounds good.
Okay, go ahead, take over, Marty.
Okay, so yeah, there are other telephone consultation codes. This is with interprofessional. So if you're going to be consulting with another healthcare provider, again, we're back to general insurance, general coding. This is not work comp, no fault specific. All right, so now let's get into a little bit more about coding and modifiers for telehealth services. There are some modifiers you should be aware of. 95, modifier 95, not 59. We're all familiar with 59, right? 95, synchronous telemedicine. Now it says the word telemedicine, but don't let that stop you from using the 95 modifier. Synchronous telemedicine service rendered via real-time interactive audio and video telecommunication system. And there's a CR modifier. This is a modifier that I never heard of until a couple of weeks ago. It's a modifier that indicates that the service being rendered is related to a catastrophe or disaster. GQ, GT. So GQ, GT probably never going to use. And there are some payers that are saying we will reimburse chiropractors for telehealth services as long as the services and the codes are listed in Appendix P. Here's another thing that many of you have probably never heard of. Appendix P, the AMA CPD code book. It lists the codes that may be used for reporting synchronous real-time telemedicine services. These codes involve communication with interactive telecommunications equipment, minimum audio, video. And then we have something called place of service that you should be aware of. Box 24B, place of service. The number 2 means telehealth. 11, you should be aware of. 11 means office. 12 means home. Here's a sample 1500 form, a claim. Just wanted to throw out a few things there. There's your 99213 with the 95 modifier. Dr. LaMonica, question for you. When billing for work comp no fault 99441, what place of service should be used?
They're saying 02 as far as I'm aware.
Okay. And then, down the road, we may do some webinars with the council on what John mentioned, rehab codes. Medicare, again, when Medicare comes out and says they're going to cover something, many insurance plans that follow CMS policy will also reimburse for those services, and maybe even companies that follow CMS policy may cover it. So Medicare came out a couple of days ago and said, we are going to pay for 97110 and 112 and 535, all these rehab services. So, I'll mention to Barbara, maybe that's something we should do on a future council webinar, is go over how to bill for rehab services. And then, there's activities of daily living. So there's a claim form. And then, a lot of insurance companies have come up with they've acted very quickly. It's kind of interesting. I'm actually proud of some insurance companies. I know that sounds strange, but they've really come out and, put out a lot of good information. This is from Blue Cross Blue Shield. Here's some information from United Healthcare. They're updating it all the time. This is something that came out from New York State on Medicaid and telehealth. Cigna came out with their policy on telehealth. It got a little confusing for me because Cigna says billing the O2 modifier may result in a reduced payment or denied claims due to current system limitations. So they don't want O2. They want 11 if you are in your office doing it, or if you're doing it from your home, the number 12. So they have a little bit of a different approach. Here's the information on the 1135 waiver. Waiving the fee for service, the temporarily suspend enrollment. So let's say you got a notice a couple of months ago that you had to, you had to revalidate your Medicare number, or you had to go into CAQH to revalidate your, your profile, or any type of reattestations. Those are all getting extended. Waiving the requirements, again, crossing state lines. Again, be careful with that. And there's another nice link, another resource. Federal government is expanding who they want to provide services. They're allowing nurse practitioners and physician's assistants to come from other states, across state lines, and help out. Like in New York, if you're a nurse in Texas and you want to go help out in New York, they'll take you. They'll help you. You'll get put into a hospital and help out, and they'll provide benefits, meals, laundry service, childcare services. So a lot of interesting things are being done. Federal government is expanding and advancing payments to healthcare providers. Also interesting information as far as I'm concerned. You'll need to update, again, if you're going to do this, get together with your staff, your associate doctors, go over the onboarding plan. You're going to need to update your financial forms, admin forms, your informed consent, HIPAA notice, your new patient intake form. So patients are going to be calling, who's going to be manning the phones and setting up these phone consultations. Have your staff call all the plans you bill for and ask for coverage on telehealth and all the codes that we went over today. Just go down the codes and see if they cover them. Update your financial policies, your Medicare forms you may have to update, Advantage Plan forms, ABN forms. And I want to talk a little bit about documentation and SOAP notes right now. So documentation, I'm going to give you a sample note. And, the note should have certain things in it, as Dr. LaMonica mentioned. Document everything that occurred. For example, you should mention right in the beginning that it was a telehealth visit and it was initiated by the patient, and the patient verbally agreed to be treated in this fashion, and they signed your informed consent form. Mention where the patient is. The patient is at home. The patient is staying at a friend's house. Where is the patient? I'm going to put that in the note. And of course, their chief complaints: back pain, neck pain, tension, headaches, muscle tightness. Let's see, what else? You could mention that the patient was a patient in your office prior to this encounter. Make it clear that it's a musculoskeletal related. I think that's important to point that out. You don't want to give the impression that you're treating, pneumonia because of the corona, COVID-19 outbreak. What else should be in the note? You get a pain scale. Ask the patient, hey, what's your pain scale? Ask the patient if, any other changes. I mean, if you saw them just, a couple of weeks ago, ask them, hey, Mrs. Jones, has any other changes have occurred in your health since the last time I saw you? And then the objective findings. Here's where I'm giving you my information because I am, I'm a chiropractor, and I'm going to give you my clinical recommendations as to how you should do the objective findings. But again, as I mentioned in the beginning of this presentation, I'm not telling you what to do. I'm not telling you have to do this exam. I'm giving you my recommendations and suggestions as a fellow chiropractor. You have to figure it out on your own, what you're going to do as far as the exam. But I don't see why you couldn't jot down just a general appearance. The patient appears to be well-developed, well-nourished, something like that. The patient appears oriented to time, place, and person. The posture, forward head posture, you could mention posture. I think you could do some range of motion, muscle appearance. I mean, if the patient says, I fell, can you look at my wrist? And the patient puts their wrist up to the camera and it looks swollen. Yes, you can, make an opinion on a swollen wrist, swelling, inflammation. Or the skin looks normal. Can you do lumbar range of motion? That's going to be up to you. I guess you could have the patient stand and say bend forward and bend backwards, and I don't know, you want to do a gait analysis, see if the patient can stand on one leg. Again, I don't know if you want to do this. I don't know if you are capable of doing it. Just giving you things that you can do. You cannot put down palpatory tenderness findings. You cannot write down the specific levels of subluxation during a telehealth visit, right? The assessment. So the patient was given a preliminary diagnosis of what? Spasm, inflammation, nerve irritation. Patient was given home care instructions like what? Ice, eat, stretch. Patient understood my advice, recommendations. And then the plan, something like the patient should schedule a follow-up telehealth visit if needed. You're not saying, okay, we're going to set you up for 3 times a week, Mrs. Jones. No. The patient was given the opportunity to ask questions. All the questions were answered. Advised to call 911 if necessary. The platform used was Zoom. Start time, end time, total time, the doctor's signature. And where were you, the doctor? At the bottom, somewhere on the form, you should indicate where you were, the doctor. Were you in your office or were you in your home office? So there's some information on documentation and just a couple other things here. Of course, scope, got to make sure that it's within the scope. Malpractice, yes. Contact your malpractice insurance company. Choose the services. You want to do work comp, no fault. I mentioned back braces. I have some clients in other states. They're doing a conference call with a patient. The patient might say, I can hardly move. My back is in spasm. I could hardly move. And the doctors are they're mailing the patient a back brace or a TENS machine or maybe a home traction device. And then the patient is told, okay, we're going to set up another conference call. And through the telehealth live video conference call, you'll show the patient how to use the DME. It's possible. Notify your patients. There's nothing wrong with letting your patients know you're going to be offering this. This is the first thing. Get that going here. Oh yeah, this is a sample that was sent to me. Actually, my wife's eye doctor got this email. I was checking it out and I liked it. So I'm sharing it with you. Eye doctors now seeing telehealth appointments, currently available, HIPAA compliant. Click a link to connect, no download. Programs or applications required, accessible from your desktop, tablet, smartphone, simple, safe, secure. Make an appointment. Liked it. All right. Provide patients, if you're going to see patients in your office, provide patients with your coronavirus safety preparedness protocols. Like what? You're going to sanitize the tables. You're going to have patients wait in their car. And then when it's time for them to come in, you'll send them a text. This is a nice link that the World Federation of Chiropractic sent out on some in-office safety preparedness. Go over the plan with your staff. How is this going to work? You're going to have patients calling, emailing. Who's going to do it? The doctor has to do the telehealth, but if you have associate doctors, I have one client, he has 7 associate doctors. He wants to give them work. He has, have another office, 55 employees. Half of them have been furloughed, but there's plenty that are doing follow-ups on, staff calling to verify coverage, resubmitting and follow-up claims. All right, so for telehealth, yeah, you could use Zoom, FaceTime, Skype, but try to convert to a HIPAA-compliant platform as soon as possible. And this is another thing we're going to be doing with doctors is telehealth etiquette. I've seen a few doctors do telehealth. They don't look professional. They look like they just woke up, and the stuff behind them, it looks also, do a practice. Look professional, speak softly, use a private room, if necessary. This is one company that I like, Zoom for healthcare. E-visits, we mentioned online portal. Number 9, check the policies. If you're going to be billing insurance, try to verify coverage prior to billing. Number 10, this is the best time to catch up on target coding videos. How many reruns of Cheers can you watch, right? How much, House Hunters can you watch? How much Netflix binge watching can you do? How many episodes of Tiger King can you watch? Take a break, watch some target coding videos. Oh, we're going to be doing a whole bunch of, I'm going to be mentioning these to Barbara. Here's our 10 upcoming telehealth webinars: how to do a spinal exam through telehealth, counseling and coordination of care, rehab, soap notes, e-visits, modifiers, telephone consultations, how to bill for nurse practitioners, acupuncturists, telehealth etiquette, PI billing and coding. Most states are paying for personal injury. So stay in touch with us. There's our contact information. Yeah, I think we're ready for Q&A.
Okay. So as we went down, I tried to incorporate a lot of the Q&A. I know Barbara usually does this, but I think there's only a few there. And Marty, jump in on if you need to with this. One is, to be clear, will Medicare cover telehealth? It covers telehealth, but not for chiropractic because of the codes. Marty, please be clear on that.
Medicare Part B. Remember, don't put all your Medicare patients into one bucket. Medicare Part B in New York is called National Government Services. At the present time, that plan only pays for spinal manipulation. We can't do an adjustment through telehealth. That's it for Part B. Part C is a totally different ballgame. There's a very good chance that Medicare Part C will pay for telehealth.
And that's the Advantage plans, which would be done through the commercial coders that don't follow the Medicare guidelines, as Marty is saying. But usually when somebody says Medicare, we're thinking of the straight Medicare red, white, and blue card. So yes, Marty, 100% correct on that. So again, I think it comes down to making the phone call and do your verification, as he said. Maybe get your staff on that for you. We're not going to tell you your fee, but in order to look up your fee, you have to use your zip code and put your zip code into the work comp book to find out what region you're in. And I do believe, I'm not sure, but I do believe in Nassau, maybe in 4, it could be 3, and that's what you use. You use that conversion factor and multiply that by 507. I don't fully understand this question, Marby. I mean, I do and I don't, but maybe you can help with this one. Can the subjective of the exam be done by telehealth and then the objective done in person? At this point in time, you don't know when the person's coming in per se. I would recommend you just do whatever you do on that call, bill it as what you do on that call. If they happen to come in at another time, you do what you do in person on that visit. Marty, do you want to add to that one?
No, that sounded right.
Okay. And again, another thing about, can a wellness patient usually in for wellness be able to bill for these visits to the insurance? You're not going to be able to bill for anything other than you can do in your office. So if it's a wellness visit, they're not calling for a condition and a complaint and a problem, then no, you can't bill a wellness telehealth visit under the insurance if the insurance doesn't cover wellness visits. Marty?
Yeah. Bill insurance for quote unquote medically necessary. Now, if it's a wellness visit, document it as a wellness visit, code it as a wellness visit, take cash for the visit, and if the patient demands that you bill it, then bill it. It will get denied. So yeah, you'll be fine with that.
And one of the last ones I see here is how do we get patients to sign informed consent for telehealth? And Marty, give them a couple of maybe ideas on how to do that besides faxing and emailing.
Any way you can get them to sign it. You want to fax it to the patient. You want to email it to the patient, and then they could fax it back or email it back. You want to mail it to the patient and have them mail it back. You know, pick a way. You can do it.
Right. Again, we don't give. Somebody asked about the fee schedules for other companies. We don't give out fee schedules. If you have a contract, you should know what your fee schedule is for the service that you're performing. You can check with the individual healthcare plans. This is not something to discuss fees. The only reason why we talked about work comp because it's a set fee schedule for all of New York, whoever's taking it. What about the insurance companies that need pre-auth like Empire Plan? Again, check with your Empire Plan. I do believe a lot of these are being waived. A lot of pre-auths are being waived for this. And only patient can initiate telehealth visit. That's something I wanted to address also. Is yes, it does have to be patient initiated. And one question was, if a patient had a prior appointment and then you turned it into a telehealth visit, that would be an initiated visit because the patient didn't know they had a visit. You can't say, like Marty said, okay, that's great for today. We'll see you on Wednesday and Friday. I'll be on at same bat time, same bat channel, and we'll talk some more. Basically, this is an emergency situation. It's a crisis situation. It's for people that need an answer, that need to talk to their doctor of chiropractic, that are going to make the call. Now, if there's something where they say, I need to follow up, you can make a follow-up and the patient asks for a follow-up and they make the appointment, you can say, yeah, we'll put it on. If you need it, give us a call. So be very careful about that. Don't use this as a marketing program, please. Marty?
Yeah, it's definitely patient initiated. And I think after our last webinar, John, there was one doctor that got confused. He thought he could call his patients and say, okay, hi, Mrs. Jones.
Right.
I am calling you because I want to set up telehealth visits with you. I want to set you up for 3 times a week. No, that's not the way this works. The patient initiates it, and now you do your telehealth visit. At the end of that telehealth visit, just tell the patient, okay, if you need me, contact me. This is the way it should be done today. Today is Tuesday, April 7th. Who knows what will be in store tomorrow?
Yeah. I know it seems like the same person asking about the fee schedules. We're not going to discuss fee schedule. You should know them if you on your, if you're a participant in the plan.
So is that it, gentlemen?
Yeah, Marty, you do have your Facebook page open there, so.
Yeah, you know what? I wanted to let everybody know every day, we call it live at 5 p.m. Every day, we are, even on Saturday and Sunday, we are doing Facebook Live updates every day at 5 p.m. So I just wanted to show everybody that you may want to go to Facebook and search us, friend us on Facebook so you can get these Facebook Live right to your computer every day, 5 o'clock.
So one more question, and I think, and if you have additional questions, I'm sure Barbara will say this, just send them in. We'll try to get them answered. But Marty, maybe you want to, I can answer part of it. I'd like you to just take this one for now. That last one that says we don't get paid for 99213 or 99212 E&M codes in upstate New York through Blue Cross. I'm assuming that's an in-network plan up there. It's included in the 9894041, which I'm still surprised they're doing that up there because I thought we beat that at one point. But how will this work with billing out? You want to answer that, Marty?
Yeah, I have plenty of clients in New York getting paid for E&M codes from Blue Cross Blue Shield.
That's
so
what I thought as well.
Maybe that doctor, yeah, I have clients up in Rochester that aren't getting paid for, I don't know if it's a, like Excelis or, yeah, there are some pockets that don't pay, but most Blue Cross Blue Shield plans pay chiropractors for E&M codes. So,
So
yeah.
again, I would pick a code, an E&M code, or one of the other codes that Marty discussed when you're talking to us, as long as you're following the criteria of that code and using the proper modifier. And I don't think we actually came out and said it, but you saw in Marty's example, the 994401, because it is actually a telephone consultation and evaluation, that does not need a modifier as far as we know for work comp medical, and I believe for most carriers, because it's not on Appendix P and it's not asynchronous. Asynchronous.
Yeah, the other thing I was going to add, even if you can't get paid, even if you don't want to do telehealth, I think it's a great idea to stay in touch with your patients. At
Absolutely.
least let them know you're there. If you just totally disappear from their eyes, your office may be open, but they might not be coming in. And then after the dust settles, they might forget who you are and go to another chiropractor. So if nothing else, stay in touch. The other thing I heard from an attorney is if you're treating a work comp or no-fault patient and you make the patients aware that you're offering telehealth and they don't come in, I was told by an attorney that could, hurt the patient. It could work against them that, in the court of law, hey, Mrs. Jones, how come you didn't go to the chiropractor? Well, it was due to the corona. Well, this doctor was offering telehealth. Why didn't you contact the doctor? I guess your condition can't be that bad. See, I don't want it to turn against the patient. So my recommendation is, even if you don't want to do telehealth, stay in touch with your patients.
Yeah, I know the attorney told you that, Marty, but I'm going to put a couple of people to rest. I don't think they're going to go to that extreme with that, but you're right. Use it. Let them use it. And listen, they're putting it out there for us for this reason, to calm patients, to keep in touch with patients, to hopefully help with some things, especially the established patients that you already know and understand their condition and you can help them with. So definitely, and remember, when you do this, you can send out emails, you can send out calls just telling them, hey, I'm just checking in on you and telling you that we are adding telehealth to our program. And if you're interested, just give us a call if you have any problems or conditions that you want to set up an appointment for. That's okay because you're not billing for that call or that email, but you're just making them aware of it. And again, you're just doing good service to your patients, letting them know you care for them and that you're there for them.
Okay, I think with that note, I will remind everybody, if you have any additional questions, as you know, you can send them to central office to me, or you can send them directly to Dr. Kotler. He put up his email address a little earlier, info@targetcoding.com. I want to thank Dr. Kotler and Dr. LaMonica for taking the time away from their families this evening to share with you this valuable information. We will be making this webinar available for viewing for a short period of time, and you'll be notified when that will get posted and how long it will be up. And with that, I'd like to thank everybody for participating, and I'd like to wish everybody good night.
Thank you, Barbara.
Thank you, Barbara. Thank you, Marty. Good night, everybody.
Good night.